Welcome back to the deep dive. Today we're looking at a document that, on the surface, seems like it's just about software installation.
Right.
It's titled Implementing a Hospital Management System Successfully, and it analyzes what high-performing hospitals do differently. But honestly, reading through this, it felt less like a tech manual and more like, I don't know, an autopsy report for failed businesses.
That's a good way to put it.
Because when these things go wrong, and they apparently go wrong a lot, it's not just a computer crashing. The whole hospital can just grind to a halt.
It's a survival issue.
Yeah.
And that's not being dramatic, that's the reality. And what's so interesting about this research is how it completely reframes the whole idea of a hospital management system, an HMS.
Yeah.
Most people, even people in the industry, they still talk about it like it's just another IT application. Did we buy the software? Is the server on? Okay, good.
We're good to go.
But this document argues it's really the digital operating layer of the entire hospital.
Yeah. That phrase, digital operating layer, that really jumped out at me. It implies that if that layer cracks, the entire operation just stops.
It does.
But, let's be realistic. Hospitals ran for hundreds of years without this stuff. So why is this suddenly an operating model transition and not just, a tech upgrade?
Because the sheer complexity of modern healthcare has it's outpaced our ability to manage it with clipboards and spreadsheets, or even with fragmented little software tools.
Okay.
Think about it. You're not just treating a patient. You're trying to coordinate a multi-specialty clinical workflow, manage bed capacity in real time, capture thousands of tiny billable charges, and report to regulatory bodies all at once.
Right. All at the same time.
The source is really clear on this. If you treat this as an IT project, you will fail. It has to be an organizational change project. You're changing how the whole business works, how it delivers care, and crucially, how it gets paid.
So let's deconstruct that complexity. The source breaks it down into 4 dimensions, and I feel like they all just crash into each other. You've got clinical, operational, financial, and regulatory.
Right. And the danger isn't the categories, it's the collision between them. You take clinical complexity, it's not just doctors need to write notes.
Of course not.
You have cardiologists ordering some really complex drug titration, and a pediatrician ordering simple vaccines. Totally different needs, but they might be treating the same patient in the same system. If that system forces a one-size-fits-all workflow, the cardiologist is just going to find a workaround, or worse.
And then there's the operational complexity. That's the logistics, right?
It's exactly it.
Bed management and all that.
Bed management, scheduling, patient access. This is the physical movement of people. If the system says a bed is clean, but housekeeping hasn't updated their status because their part of the system is clunky.
Then you have a patient stuck in an ER hallway.
For hours. Exactly. That's an operational failure.
Right.
And it's caused by a digital disconnect.
Then there's the one that always seems to cause the most pain, financially at least. The financial complexity. The source is pretty blunt about this link between care and billing.
Oh, it has to be. In the old world, a doctor does a procedure, writes a note, and then 3 days later, some coder in a basement tries to guess the right billing code from that note.
That sounds like a recipe for losing money.
It's a recipe for revenue leakage. The whole game now is charge capture. The system needs to be smart enough so that when the clinical action happens, the financial transaction is created automatically, in the background, with all the right codes.
And the 4th one, regulatory complexity. This just feels like it gets heavier every single year.
It does. Mandated reporting, insurance integrations, national health platforms. We can get into the Saudi Arabia example later, but the bottom line is, if your system can't speak the language of the regulator, you're in big trouble.
Okay, so we've got these 4 huge complex areas all grinding against each other. And the big aha moment from the high performers is realizing you can't just buy software to fix it. You have to fix the organization itself.
That's the key.
So let's get into why this goes off the rails so often. The section in the source on why implementations fail was brutal. The first point was fragmented ownership.
The classic silo war. You see this everywhere. The IT department, they own the configuration, making sure the buttons work.
Right.
Then the clinical leaders own documentation standards. And finance, they own the revenue cycle. And they hardly ever sit in the same room to make a decision together.
So what happens then? Practically speaking, the CFO wants to add 5 required fields to a screen to capture more billing info.
Yep.
But the chief medical officer wants to remove those same 5 fields to save doctors' time. If they have fragmented ownership, who wins that fight?
Usually whoever has the biggest budget or shouts the loudest.
And that is the failure mode.
The source says the high performers, they establish cross-functional governance before the project even starts.
So like a steering committee.
Exactly. A body where the CFO, the CMO, the CIO, they all have to define the rules of engagement. They have to agree that, okay, we'll tolerate 2 extra clicks on the screen because it saves us 15% in denied claims down the road. Without that, the developers are just caught in the middle.
And they end up building a Frankenstein system.
A complete Frankenstein, which leads you right into the second trap, digitizing inefficient processes.
Ah, paving the cow path. I love that image. But isn't the temptation always just to say, hey, take what we do on paper and just put it on the screen? It seems faster.
It's almost never faster. Actually, it's usually slower.
Yeah.
Signing a piece of paper takes 2 seconds. Logging in, navigating 3 menus, clicking sign, that takes 20 seconds. If you just digitize a bad workflow, you're just cementing that inefficiency into the foundation of your hospital.
Can you give me a real-world example? What does that look like on a hospital ward?
Okay, think about admissions. On paper, maybe the nurse fills out a form, then a clerk copies some of that info into a logbook, and the doctor comes in and asks the patient the same questions all over again.
I feel like I've lived that.
We all have. Now, if you just digitize that, you have the nurse typing it in, the clerk retyping it on a different screen, and the doctor typing it in a third time. You haven't shared the data. You've just given everyone a keyboard to do their own little isolated task.
So that's what the source means by identifying 5 to 7 high-friction workflows. It's about stopping that before it even starts.
Exactly. Don't try to fix everything at once. Pick the hardest things. Admissions, discharges, medication administration. Map them out. Find the waste. Find the duplicate steps. Fix the process first on a whiteboard. Then and only then do you configure the software to support the new, better process.
The third big trap is change fatigue. And this feels like it's often dismissed as just, people hate new things. But in a hospital, resistance isn't just grumbling, it's actually dangerous.
It is. The source points to informal workarounds as the symptom you have to watch for. This is shadow IT. It's the little sticky note on the monitor that says, don't use the meds field, just type it in the free text comments.
And as soon as you type it in the comments, that data is useless. You can't run a report on it, you can't bill from it.
Precisely. You've destroyed the data integrity for the whole system. The way you fight this is by realizing that go live is not the finish line. High performers, they plan for a stabilization and optimization phase.
What does that mean?
It means they know day 1 is going to be a mess. People will be slow, they'll be frustrated. So they budget for a team to stay on the floors for months, watching, listening, and tweaking the system to make it more usable. They don't just declare victory and walk away.
Okay, so let's flip this around and talk about the solution, the playbook. This is what the high performers do differently. Strategy 1 is pathways over modules. That sounds like a direct attack on the silo problem.
It is. 100%. Most of this software is sold in modules. You buy the pharmacy module, the lab module, the billing module. So the lazy way to implement it is to just create teams around those modules.
But a patient doesn't walk into the pharmacy module.
Exactly. A patient walks into the ER, gets sent to radiology, and maybe to the ICU, and then they get discharged. That's a pathway. High performers organize their entire implementation around these end-to-end care pathways.
So instead of asking, is the lab module working, you ask, is the chest pain pathway working?
Correct. You trace the data. When the patient gets registered in the ER, does that information flow seamlessly to the lab when a blood test is ordered? Does the lab tech have to re-enter the patient's name? When the result comes back, does it pop up on the ER doctor's screen? Organizing by pathway forces you to focus on the handoffs, the integration points, and that's usually where things break.
Okay, let's talk about strategy 2. Linking clinical and financial. It feels like the core of the whole thing. The source says, charges originate from documented clinical activity. Unpack that for me.
This is the holy grail for the financial side of the hospital. In the old world, clinical notes and billing were 2 different universes. Now, the goal is to link them. If a surgeon documents appendectomy in their clinical note,
The system should just know what to bill for.
it should immediately trigger the corresponding billing code in the financial background. No human intervention needed.
But why is that so critical? Is it just about being faster?
It's about validation and preventing denials. If that link is real-time, the system can check the rules immediately. So, for example, maybe an insurer requires a blood pressure reading before they'll pay for a certain drug.
Right.
If the clinical and financial systems are linked, the system can literally alert the nurse at the bedside. It can say, hey, you need to record blood pressure before giving this, or insurance will deny the claim.
Wow. So you're catching the mistake before it ever becomes a financial loss.
You're moving the entire financial validation process upstream, right to the point of care.
Yeah.
That's how you reduce revenue leakage, the money you earned but never collected because of some paperwork error.
All right, strategy 3, compliance as a design constraint. And this is where that Saudi Arabia example from the source comes in. Why single out that region? What's going on there?
Well, Saudi Arabia is a really interesting case study because they're going through this massive nationwide digital health transformation. And it has very, very strict regulatory requirements. They have national platforms that hospitals must integrate with. It's not optional.
So it's a high-pressure test case for these ideas.
Extremely high pressure.
Yeah.
And in that kind of environment, you can't treat compliance like a report you run at the end of the month to see if you messed up. If you do that, you're facing huge fines or even shutdowns. You have to treat compliance as a design constraint.
Meaning the system literally won't let you do the wrong thing.
That's it. Take eligibility checks. In a regulatory world, you have to validate that a patient's insurance is active before you provide the service. So high performers build that right into the workflow. The scheduler can't even book the appointment until the system has pinned the national insurance platform and gotten a green light.
The compliance is baked right into the code.
It's not left up to a human to remember to do it. It's just how the system works.
Which brings us to the technical backbone for all of this. Strategy 4, enterprise integration architecture. We've mentioned acronyms like LIS and RIs. Why does the architecture matter so much? Why can't you just plug things together?
Because hospitals are these messy, complicated ecosystems. You've got the main HMS, sure, but then you have the LIS for the lab, the RAS for radiology, PACES for the x-rays, a separate system for the pharmacy robots. And what low-performing hospitals do is build point-to-point interfaces. A custom script to connect the HMS to the LIS, another one for the HMS to the RIS.
That was a spaghetti code.
Total spaghetti. And the second you upgrade your main HMS, all those fragile little custom bridges break. High performers use a disciplined architecture. They define master data ownership.
What does that mean?
It means deciding who owns the single source of truth. For example, the HMS owns the patient's name and birthday. The LIS owns the lab results. They use standard protocols, so data flows in a predictable, standardized way.
So if you swap out your lab system in 5 years, you don't have to rebuild everything from scratch.
Exactly. It makes the whole thing scalable and modular. Without that, you get these split brain issues where the lab system thinks the patient is 45 and the HMS thinks they're 46. And that's not just a data problem, that's a patient safety risk.
Okay, so we've built it right, we fixed the workflows. How do we know if it's actually working? The source says not to use system uptime as a metric.
Yeah, that's a vanity metric. My toaster has 100% uptime. It doesn't mean it's running a hospital.
Right, so what should we be measuring?
You have to measure business and clinical outcomes. Outcome-based indicators.
Ooh.
Don't tell me the server's on. Tell me that the days in accounts receivable dropped from 45 to 30. That proves your financial integration is working.
And on the clinical side?
You look at things like documentation completeness or order turnaround time. If the system is wrecking, the time from when a doctor orders a blood test to when the lab actually sees that order should be instantaneous. If you see a lag there, you know you have a workflow problem. High performers obsess over these functional metrics, not IT metrics.
Now, to pull all this off, the source makes this distinction between a provider and a partner. Is that just sales jargon? I mean, every vendor calls themselves a partner.
It sounds like it, but the text is actually very specific. It's about the scope of responsibility. A software provider sells you a license. They hand you the code in a manual and say, call our help desk if it breaks.
Good luck.
An implementation partner, on the other hand, has skin in the game for the whole transformation.
So they're the ones sitting in those tough governance meetings we talked about earlier.
Yes. They're helping you manage the stakeholders. They're bringing best practices from other hospitals. They're the ones who say, don't configure it that way. We tried that in Dubai and it was a disaster. Do it this way instead. They stay through that stabilization phase. You can't just buy code for this kind of change. You need a guide.
This has been a really intense look at something that gets dismissed as just back office IT. So let me circle back to the beginning. If I'm a hospital CEO listening to this, and I'm about to sign a huge contract for a new HMS, what's the one thing I absolutely have to do first?
The source calls it a readiness assessment. And it's really a look in the mirror moment. Before you spend a single dollar on software, you have to honestly ask, does our organization have the maturity for this?
Do we have the governance to make hard choices?
Are our workflows even documented, or is it all just tribal knowledge in people's heads?
And if the answer to those questions is no,
Then you need to fix your organization before you start the implementation. If you bring a sophisticated, rigorous software platform into a chaotic, immature organization, the software won't fix the chaos. The chaos will broke the software.
That's a really sobering thought. The technology just amplifies what you already are. If you're efficient, it makes you more efficient. If you're chaotic,
It just makes the chaos faster. This is a perfect summary. The HMS is the digital operating layer, but the human operating layer has to be solid first.
This deep dive has really shown that success here isn't about the code. It's about the discipline. From getting the C-suite aligned, to redesigning your core pathways, to baking compliance right into the design, it's a huge undertaking. But as the source says, it's really a matter of survival. Thanks for unpacking all this with me.
My pleasure. It's a complex topic, but getting it right saves lives, and it saves the business.
And for all of you listening, the next time you're in a hospital and you see a nurse scan a barcode, just remember that little beep is the endpoint of a massive, incredibly complex digital nervous system. We'll see you on the